So as I said, this is a review of chapter 9 from CNA class. And strangely enough, this is also chapter 9 in this book. A review of rehabilitation. As a patient care technician, you may work in other areas aside from the long-term care. There's rehabilitation centers all over the place for physical rehabilitation. Many patients go into facilities for some type of rehab, whether it be physical rehabilitation because of disability or maybe restorative care and so on. So you're not limited just to a long-term care hospital, but also inpatient rehabilitation centers. So what is the rehabilitation? What is the goal? If you remember, the main goal is to take somebody from illness to health, from disability to ability. All right, so return them to their normal ability, as normal as possible. So you're going to be part of the physical rehab team in this case. I did see some positions for restorative care assistants, and this is a position that can be held by a CNA or patient care technician in a rehabilitation center. So the settings for rehabilitation, some of the areas, like I said, they're inpatients. That means the patient will go be admitted into the facility for a minimum amount of time. Most of these residents will be admitted for a minimum of 21 days, I believe is a minimum, and after that it can go on from there. Some facilities are outpatient rehabilitations where they go in, get therapy for about an hour or so, and then they return home. There are different, there's just a lot of different ways, modalities that patients receive physical therapy. So your job, your scope of practice in rehabilitation center is limited to a more technical part, setting up equipment, assisting with ambulation and transfers and so on. And of course, the physical therapist will be the one to prescribe the plan of care for the patients in rehabilitation for whatever reason they're there for. There's a lot of reasons that the patient end up in the facilities. Most commonly, falls for the elderly. We have a lot of younger patients that go into rehab because of they suffered a stroke. Patients that maybe have deconditioning, they either have weak hearts and they're unable to perform their normal activities of daily living. So any decline in their functional abilities is merits a physical therapy evaluation and perhaps intervention, such as admission to the inpatient or even therapy at home, which is another type of therapy. Uh, Cervical injuries, said fractures of the hip, fractures of the femurs, any kind of fracture or accident that disables the patient will require that they be probably admitted into facility. Usually they go to the hospital, they'll get their surgery, they'll get repaired if possible, and then from there they'll be recommended to be admitted into into our rehabilitation center. The most of the long-term cares or nursing homes are now most of them are rehabilitation. They're not called so nursing homes so much, but they do have different areas. They have the long-term care where the residents with usually dementia are sit in, and then they have the skill side of the nursing home for residents that require skilled interventions such as therapies and nursing care and so on are also housed in. So there's going to be different areas of the long-term care facilities where they can be admitted into. So the phases of rehabilitation. The first one is the acute phase. The acute phase, remember, acute means urgent care. So if someone falls, obviously in the home, they're going to need acute care. So this would be the acute phase. Usually, they go into the emergency room, they get diagnosed, and then they get admitted into the surgical ward, the medical surgical unit, where they will await the surgical evaluation or the surgeon evaluation rather. So the surgeon comes in, or in this case, maybe a fracture of the hip. The orthopedist, specialist in repairing fractures, will go evaluate the patient and recommend their, surgery or other kinds of interventions as needed. So once they evaluate him, the surgeons will usually require that their primary care physician, whoever it may be, either a hospitalist doctor or their attending physician from outside the hospital, they're going to need medical clearance. So before any patient goes into surgery, they need to be cleared for surgery. That means that the patient has to meet all the requirements to be physiologically stable to undergo a surgical procedure. That means that the patient's electrolytes will be needed. That means that they're going to need an EKG and other medical history. Any problems, medical problems that they have to be under control, such as high blood pressure, diabetes, and so on. So all that criteria has to be met before the person can undergo surgery. Because if not, then other complications can occur during this surgery, which of course are not wanted. So once the attending physician clears a patient for surgery, they will go to the surgical unit. But before then, the person may require several treatments, including antibiotics. Usually administer antibiotics, what we call prophylactically. Prophylactic means it's preventative. So the surgeon knows that the person is diabetic and they may have a high risk of contracting an infection to the surgical wound. They may administer or order an antibiotic to be given right before surgery. That way, the patient has some kind of treatment in case the incision is made in the skin. The skin is open, and everything can go in there. So, but that's why antibiotics are prescribed prophylactically before surgery. After they come out of surgery, they go into the recovery unit, the post-surgical recovery unit, something like that they call it, where they're being observed to recover from the anesthesia. Remember, anesthesia is only used for management of pain. That is the only reason why anesthesia is used. Obviously, nobody wants to undergo, serious surgical intervention without anesthesia. So after they get out of surgery, they go to this unit, and because they're very heavily sedated, they're pretty much put to sleep. They might have been intubated as well. So the respirations, the vital signs are going to be monitored very, very closely. You can even be part of this team if you choose to work in a surgical unit. So the post-surgical unit is limited to 3 or 4 patients at a time. Give me 1 second. Okay, so the acute phase is the first 24 hours after surgery. So after the patient gets out of surgery, they go to the post-surgical care unit. They stay there for a few hours until they are stable enough to go to the medical surgical floor. Once they're in the floor, we usually get report from the post-surgical unit nurse who tells us everything that the patient underwent, including the medications that the patient received, such as the type of anesthesia that was used, other vital signs, their oxygen saturations, and so on. It's really important that we get this information because um, so we can have a baseline to compare. In case a patient declines for some reason, they start having trouble breathing or any other problem, we can anticipate, hopefully, and prevent these from digressing from getting worse. So the other nurses will give us what they call a handoff report. And in this case, I will also speak to you as a patient care or CNA and tell you what's going on with this person. Why are they coming? What's wrong with them? We call a plan of care. Can this patient start eating again? Already in a MPO, or they clear liquid diet? Can they get up to the restroom? What is their weight bearing status? And vital signs, how often are we going to be measuring vital signs? So all this information has to be shared with you so that you can be involved and be part of the team and help take care of this patient more effectively than if I don't share information. So the acute phase is for the first 24 hours after surgery or injury. They're going to be observed constantly under the care of the whole entire team. For the most part, most patients are stabilized in the emergency room, so they're not in any kind of danger. If they are very severely ill or injured, then they will probably be moved on to the intensive care units, not so much for surgery. The subacute phase, after they are been stabilized, usually in the medical surgical ward, they call it subacute phase, the person will start to recover. So if you remember when we talked about holistic care, this is the time when you need to start looking at a person in a complete way, in a holistic manner, right? We're not just looking at the person with a surgery. We're looking at everything, every body system the person has, you have to take into consideration. You have to be very observant, especially if they just came from surgery. That is why it's very important that you're familiar with the surgical procedures and the post-op care, right? Post-operative care is very, very important because a person who seems to be completely normal, okay, completely normal, completely stable, may start to digress. Okay, so you have to be very, very observant and report any changes that you might notice in a person. So the goals of rehab again are for the patient's physical, emotional, and social functions to be restored as normal as possible for the patient. A lot of these patients don't usually return to their 100%, but they might at times. Some centers that you can work in, again, is brain and spine for injuries. Most of these are located within the same facility in the inpatient rehabilitation. Stroke patients is very common. Burn injuries, that's a completely separate, different rehabilitation. Acute mental status, we talked about psychiatric health, which is another area that you can pursue if you want to work in that type of line of work. Drug or alcohol addiction, this is, I mean, again, completely separate type. This is not physical rehabilitation, but a different kind of rehabilitation centers. Uh, don't be afraid to jump into these different areas because you've never seen them. A lot of us, that when you start in the medical field, you've never seen a lot of these things. They're completely new. So you learn as you go, right? Hopefully you get somebody that is experienced and is a good instructor or orient preceptor, and they can, show you the ropes of the line of work that you're in. So don't be afraid to jump into different areas of the medical field. Your physician or physiatrist is the rehabilitation doctor. They're the ones that really focus on the rehabilitation uh, plan of care. Whatever the physiatrist recommends, the physical therapist will usually, or the I'm sorry, let me say the physical therapist will make recommendations to the physiatrist, and usually they will agree on that. Rehabilitation nurses is actually a specialized area. You can go into this field if you choose to later and specialize just in this line of work. You'll find occupational therapists, which deal more with the upper body. That means they work with patients, more stroke patients, or things that they need to relearn. If they need to relearn how to feed themselves, how to dress themselves, those kinds of skills, then the occupational therapist will be in charge of that part of the plan of care. Versus your physical therapist, your physical therapy assistants, they're more focused on the actual walking, balance, strength, the lower part of the body, okay, and of course their arms as well. So physical therapy is more movement, right? Walking, standing, transferring, strengthening, and so on. Balance, very, very important. So physical therapy deals more with that. You also find speech therapists, which of course deal with patients that have had maybe stroke or some kind of spinal cord injury where they cannot speak, they lose their speech or their ability to swallow food and water. The speech therapist will be working with them. And rehabilitation aides or restorative aides are CNAs or patient care technicians that decide to work in this area. Orthotists are people that make specialized devices for people that maybe suffered an amputation. They need some kind of special device, a brace or something to that respect. The orthotists are the ones that design it, and the prosthetists will make the actual equipment. There's a lot of people that are involved in the care in the rehabilitation center. Sometimes, obviously, they're not all there at once, but you get to know the different fields, and hopefully one of them will interest you. And spinal cord injuries. The spinal cord injuries are very severe. Obviously, patients that have trauma, car accidents, falls, or any kind of spinal cord injury has a very specific type of care. In the hospitals, you'll find some areas that are very specialized in spinal cord injuries. You will learn how to work with these patients that require very specialized care and movement, because the spine is meant to be in a vertical position. You have to always remember that when you're going to reposition someone that had a spinal cord injury, they must always be moved in a what we call a log roll, like a log, like a piece of wood, right? They have to be turned in one unit, right? And make sure we maintain the spine in a vertical manner. We cannot, turn the legs first, or cross the legs or things like that, because that moves the spine. And a person has any kind of surgeries in the spine, and you move the legs, the spine moves, and you might cause injury. So it's you have to be very familiar with the plan of care. However they instruct us to work with this person, that is what we need to follow to minimize the risk of re-injury. The effort of rehabilitation, what really affects the progress of rehabilitation? I think a lot of it is psychological. From one day to another, someone is injured and their whole life changes. It's turned upside down. They lose a lot of abilities. They're going to be in the hospital, and there's just so many things, and all these things go in your head. So the attitude, right? The way they approach, okay, their injury or hospitalization will really affect their ability to recover faster. So the person's attitude and coping skills to their new limitations. So we healthcare providers have to make sure that we are always a positive uh, light on them, because as you know, since the surgery, everything it seems to be gloom and doom. Like nothing is ever going to be the same again. So we have to remember that we cannot bring negative feelings or emotions into the picture, because they don't need that. They want everything needs to be positive for them so they can make a quick recovery. The response of the family members and caregivers to the person's disability. We always encourage the family to be part of the care plan so that they can learn and be familiarized with what's going on with the family member. When we try to keep things too shy, or we keep them out of the plan of care, that really affects their ability to participate, and they feel left out. And for that reason, a lot of patients may or family members may have negative perceptions about healthcare team members. I know that when we are kept out of things, we're not kept in the loop. We don't know what's going on. We have all these questions. People feel very skeptical. They're kind of wondering what's going on. Are they really doing the right thing for my family? So again, make sure that everything is explained to them as you're going along. Whatever is within your scope of practice, of course. Don't explain things that you're not familiar with. The person's overall health status, again, the less medical problems the person has, the faster they're going to recover. Their age obviously is a big factor. Older people recover a lot slower than young people, so it's gonna make a huge difference in their recovery phase. Traumatic brain injuries are very common nowadays, especially with contact sports such as football. Uh, a lot of young people suffer concussions, temporary, like they black out for a while, and the brain is kind of shaking. It's like shaking an egg. You can feel inside, everything that moves in there. Well, a concussion is the same thing, but except, what moves around is your brain inside your head, and this really has a big impact in the ability to function. So any changes in the mental status caused by by the concussions can affect their neurological functions. Skull fractures are severe. Obviously, they don't happen too often. It's very hard for your skull to break. But they don't happen often. Cerebral contusion is a more severe. It's like a higher level of concussion. Usually more common in accidents, when you hit your head hits what you call it, the steering wheel, or you have a fall and somebody falls on their head or injures their head, or somebody hits you in the head with an object or with a blunt object. Obviously, you're going to have a cerebral contusion or a big bruise in your head. You require a lot of force, to cause damage. So cerebral contusions are not that common. Now, hematoma is blood pooled underneath your brain. That is pretty serious because if you have a lot of blood be collecting inside your head or your brain, okay, it's very serious because it's going to put pressure on your brain. It's going to cause a lot of complications. So that requires surgical intervention. In this case, usually the person will have a hole drilled in their head so that they can relieve the pressure and possibly some of that blood that is pulled under the skin. Okay, so it's a subdural or epidural hematoma is a serious complication. Most often occurs from trauma such as car accidents, injuries to the head, or also from strokes. When a person suffers a stroke, a hemorrhagic stroke, and there's blood that pulls inside the brain in the epidural, which is the outer layer of the brain, the person will require a a hole to be drilled in their head to be able to drain out the blood and the relieve the pressure, the intracranial pressure that stays there. All right. So where's the other ladies? They disappeared.
Closer, aquí estoy.
No, y las otras ahí estaban ahí, se fueron. They lost their signal. We're having exams today for the students, for some students from outside that are not our students, and they're coming in through the door and just come over here and you want me to answer questions, and Ms. Ray's not here yet. Anyways, so let's continue, Ms. Erica. Were you able to apply at any positions, Erica?
Yes, I did, sir. Ayer.
Where did you apply? You haven't informed me.
At the dialysis center y en el que me mandó.
El Loyal Source o algo así.
Yes.
Okay. All right. ¿Y a cuál dialysis center?
El de Vita or something like that.
Davita? Okay. All right. If they contact you, if they ask you about your CNA, you should have it by then. They usually give them a couple of days. So if you did it yesterday, that's Monday, maybe by Wednesday, yeah, tomorrow you can call and follow up. I know that if you can give me the exact DaVita, because I know there's several, which one you applied to, do you know which one?
No, creo que es el de McAllen o el de Mission. I can't remember.
Parece que tenemos un amigo que trabaja ahí en el de Macal, en el DaVita. Se llama Jorge. Y era estudiante de nosotros también. Yo creo que tiene ya como unos 6 meses que empezó ahí. Parece que es en ese. Le voy a preguntar para que me ponga en contacto con su supervisor para poder meter una patita ahí en la puerta, ¿no? Pero bueno, en fin. So, in neurological or care, or what you call it, spinal injury rehabilitation, they have different levels of or different tools that we can use to evaluate the person's neurological function. And it goes in different levels. So you can see on the PowerPoint the different levels. Level 1 of somebody that's completely comatose, they don't respond at all, that would be level 1. Level 2 is when they start to wake up, and they also use this tool after they After they wake up from surgery, after they give you anesthesia and you're starting to wake up, you can evaluate the patients by using this scale. Once you get to know the skill really well, you can tell what level they are just by talking to them and listening to them. Level 3, localized response. So they're more alert, they understand what you're saying, okay, and they'll respond to you. Level 4, confused and agitated. The person is confused. Now, this is not for dementia, but someone that had some kind of maybe a head trauma, right? Like a concussion. That would be like a level 4. Level 5, confused and inappropriate. They're more than just confused, right? They don't know what you're saying. They don't understand, or they may answer incorrectly. That's level 5. Level 6, confused and appropriate. They're more focused. That means they're recovering from level 5, but cannot pay attention for about 30 minutes. So that's level 6. Level 7, it's almost normal, almost a normal. They do things purposely with a purpose, like trying to feed themselves or trying to, provide personal care. And then, of course, level 8 is somebody that's completely healthy. So in most cases, you'll be dealing with people after surgery in levels 1 to 3. That's the type of person or evaluation that we do. But that's just for your information, so you can know what we use to evaluate them after they come out of surgery. Bleeding and swelling of the brain tissue after trauma results in an increase in which of the following? Where does it occur? Is it traumatic brain injury? Intracranial pressure. Oh, it's asking where. So it happens in the brain between the epidural, that little layer of brain that we have. Again, most commonly we see it a lot with people that have strokes. They have a lot of blood that stays in the brain, and that's considered a hematoma, subdural hematoma, or epidural hematoma. What you need to know, if you're going to be part of the healthcare team, you need to be very observant. Reporting the changes. That's why when we first receive a patient, we make this evaluations using the tool I showed you earlier. You have to make sure that you make these observe these subtle changes, increasing headaches or complaints of head pain, dizziness, agitation. Your breathing pattern becomes faster or slower. Sudden weakness or loss of function on one side of their body, slurred speech, kind of like a stroke. So these changes have to be reported immediately. I have a CNA that works with me. She's an older lady. She's very good. She observes everything. She knows the patients, up and down, and any little change that she tells me, I listen and I go observe the patient and I assess them. And most of the time, she's right. She's just very observant. Not only because she knows the patient, but because she actually observes the patients from head to toe. So report to the nurse any change in the level of consciousness. If you're having trouble waking them up, they're too sleepy, too groggy, they don't want to wake up, that should be reported. The vital signs are up or down, the blood pressure drops or the blood pressure goes up, you need to report that vital signs complete, just like not just blood pressure, but their pulse and their breathing patterns. Signs or symptoms of a stroke that were not present before. If they didn't have any kind of a speech impairment, if they were not drooling, if they could move their arm before, now they can't. All these things are, of course, have to be reported immediately. The person with chest pain, we know that, very important. Sweaty skin, the skin is clammy. It's like feels like cold but sticky at the same time. That may be because their blood pressure is low or their blood sugar is low and so on. Any trouble breathing? Uh, I had an experience when I first started as a nurse. It's kind of a learning experience. The patient came back from surgery, an older lady. She came back from surgery, and it was I think it was a gallbladder removal. The gallbladder, pretty typical. It's pretty routine. And the patient was in the room. It was a shift change. They just rolled her in there. The patient was in the room. I went in there. She was in the bed. The bed rails were up, and so on. And then I said, I'll come back and check her on later again, whenever, as I make my rounds or whatever. And then later, the surgeon came in to see the patient after surgery. and the patient was in the bed, and he came in here, and he was calling out for the nurses, and the patient was dead. The patient was dead, uh, and I was like, "How can the be?" I saw her; she was there sitting in the bed, right? And to make a long story short, what happened was that when the patients go to surgery, they get a medication to dry up their secretions, their saliva and all that, right? So that they don't start choking on their own saliva. So what happened was that when she came back from surgery, this person, or during surgery, she developed what they call a mucus plug, a thick piece of mucus that stayed in her airway. So when she tried to cough it up, and she couldn't cough it up, and she couldn't make a noise because her airway was clogged, uh, this happened. Okay, this is a true story that happened to me. One of my first experiences. Obviously, not a good experience, but anyhow, the lady died, and after they came back, investigated, they said it was the mucus plug. So it wasn't nobody's fault. I don't know if it was anybody's fault, but the thing is that medications can cause side effects. Something that we need to be aware of. We need to be, uh, alert and make sure that we're observing these patients constantly. So nowadays, they not because of that, but as we're moving along, we see a lot of changes that occur to improve the patient care, the safety of the patients, including communication. So now we have something they call SBAR report, SBAR. I forget what it stands for, but it's a report that we give each other when we hand off patients from surgical to the floor and so on. So we have to do this kind of report or communication every time. The common thing that you will find are surgical repair of the hips. Those are very, very common. Uh, Very common in the elderly. The hips, as they get older, they become brittle because of osteoporosis or other conditions, and the older people tend to fracture. They fracture either completely or they completely the femur completely breaks, so they have to undergo hip surgery, and they usually we're going to put an implant in there to repair the hip. It depends on the type of fracture that the person gets. Will depend the type of device that they're going to be getting, but a lot of them are able to walk again. Maybe not exactly the same like they did, but it's a very good procedure that is done very commonly on older people. They call it hip surgery because of the hip bone that you can see here. You can see the PowerPoint, right, Erica? So hip surgery again is very common, and you'll be dealing a lot with this. You have to follow the specific plan of care for the patients. Unfortunately, it depends a lot on the size of the patient. If they're petite or if they're heavy set, it's going to really affect the plan of care, their weight bearing status. So you have to make sure that you're looking out for the surgical incision, for the weight bearing status, for the diet, pain management, make sure their bowels are moving, and so on. So it's really important that we keep an eye on the entire person, not just the surgical site itself, but everything about the patient. Somebody that can have a surgical amputation of a leg or a foot or a toe is going to require rehabilitation because our toes obviously help us a lot with balance. And if we incur an amputation, believe it or not, you're going to feel the difference. Okay, every finger, every toe has a function, has a purpose, and when you're missing that part of your body, you're going to realize how important it was. So more so if they have a complete amputation. Sometimes it's below the knee, we call it a BKA, below the knee amputation, or sometimes their amputation can be above the knee. So you're only going to have a very short part of your leg to use, and for that reason, these patients will receive a prosthesis. Okay, so an orthotist and a prosthesis will develop a device. These devices are hopefully they've been put to use by the patients. A lot of times they don't want to use them because they're kind of difficult to manage at once. They're difficult to get used to, and they rather be in a wheelchair instead of using the prosthetic device. But we should always encourage the patients to use these prosthetic devices because that's how they're going to return to their normal level of function as normal as possible. So we need to encourage that use. Some of these patients that have amputation of their legs will experience something called phantom pain. I think we discussed it in CNA class, but phantom pain is real pain. What it is that patients that have this will experience pain where the old, the limb used to be, where the leg or the foot used to be. They still have sensations, and it's mainly because the connection between the brain and that part of the body is still there. Although the part is not there, the connection, the neurological connection is still there. So they still feel pain, they still feel itching, they feel like they still have that part of their body, even though it's not there. So phantom pain is very real, and we need to report it as such. Burns are also a very specialized area. Burns can vary in the severity. They are staged in degrees, first, second, and third degree. And then we also divide it into parts of the body that are burnt. That'll be the severity, right? So persons can have a first degree burn, right, which is very superficial, um, just kind of redness. There's actually no breakage in the skin. You have your second degree burns, where the skin appears red, and you get a blister. Okay, so once you get a blister, that means it's a second degree. A third degree of burns are completely burned areas. There may be no more white, red, or brown, but more brown or black tissue. So these are third degree areas. Now, we measure the severity of burns by uh, how much part of the body is actually burned uh, during the trauma or the accident. And we call it the rule of nines. The rule of nines. So depending what part of the body, for example, if it's a leg, it's 9% of your body. Now, it doesn't have to be your entire leg. It could be part of your leg. Your arms are 4.5%, and so on. So we use this rule of nines to to um, to determine, okay, the percentage of bodies. Now, when somebody gets burned, more importantly, uh, if it's a severe burn, like like a third degree burn, you you may not feel pain. Why? Because when you have a third degree burn, the nerve endings that were there are burned, so you will not have pain. What's more serious is that when you have a burn, there's a lot of changes in the circulation. There's a lot of changes. There's going to be an increased amount of fluid going to that part of the body to repair it, so the person's become dehydrated. There's a series of electrolyte imbalances that occur during the burn. So we also have to keep that in mind. So it's not just about caring for the skin, but it's about the physiological integrity, including their electrolytes, their hydration, and everything about them. Of course, pain, if they do have pain, we have to address it as well because it affects every other body system. So helping or caring for someone that is a burn victim is a very, very serious condition. And I know down here in the valley, we don't have uh, specialty areas for burns. They usually have to be transported to other parts like Corpus Christi or other parts of the state. Here in Texas, we don't have burn uh, specialty areas. The book doesn't talk about knee surgeries, but knee surgeries are very also very common, just like hip surgeries. Remember that to look at the patient in a holistic manner. We're gonna care for the surgical side. We're gonna observe the surgical side, make sure it's not bleeding, it doesn't get infected, they don't start hemorrhaging, like bleeding a lot. We have to assess for circulation to that part of the body, whether it be a foot or a leg. Make sure they still, have their toes are pink. We have to evaluate for blood clots. Blood clots is a very common complication of surgeries because after surgery, well, during the surgery, they're flat on a stretcher or gurney for a prolonged period of time. So we're talking about an older person who may have a very poor circulation. So this increases the risk of them getting um, blood clots. Very common. So what do? Well, we try to prevent it. Firstly, with medications, we give these patients. We start them on a medication called Lovenox, which is a heparin. You remember, heparin is a anticoagulant, like the ones in phlebotomy. So we inject heparin into the patient to prevent them from getting blood clots. We also implement other measures such as applying the TED stockings, the white stockings, elastic stockings, compression stockings. All these things we apply the sequential compression devices, which are they're cuffs there that inflate and deflate to promote circulation. Um, so anyway, so we do everything that we can to prevent blood clots from forming because they really create a lot of other problems for the patients unnecessarily. But again, we try to do as much as we can to prevent it, but they still happen sometimes. Okay, so as far as amputations, as I mentioned earlier, they're going to have their acute phase and subacute phase, meaning right after surgery. Once they become amputated, we have to care for the surgical site. They're usually going to have staples or sutures, depending on the size of the person or the thigh, the leg. Look out for any signs of infection to the site. Remember, it's redness or any drainage, increased swelling or pain or pus coming out. We have to report that. But after that, that goes on, the patient will go into the chronic phase of rehabilitation. And I see it a lot with patients that have very bad circulation. They end up with amputations of their limbs or the legs. So we have to help them because it's going to be a long process. Actually, it's a lifelong process. They have to adapt to things, to the way they live, because they no longer have a leg or a foot. They have to adapt, in many ways. And we're, believe it or not, indirectly part of the rehabilitation. Even after they go home, they will receive some kind of therapy sessions and maybe outpatient therapies and so on. So there's a lot of things that happen after an amputation, especially from a family point of view. They're going to need a lot more help. Is there anybody at home to help them? What can they do for themselves? They're going to need occupational therapy, physical therapy. Uh, there's just a lot of things that affect the person that has a surgical amputation of a limb. All right, so in this chapter, let's see what we covered. The goals of rehabilitation, the phases of rehabilitation, the different areas that we have to address when someone is going through rehabilitation, the physical aspect, the physiological, the mental, the psychological, and all those things. Factors that can affect outcomes of rehabilitation. Again, the way they perceive rehabilitation, or they have a positive attitude, or a negative, or they not want to participate, and so on. The role of the PCA, PCT, in caring for a person with spinal cord injury. Again, this is very specific care, plan of care that needs to be followed when somebody has a spinal cord injury, because we don't want to re-injure the area. Uh, I remember patients that were having spinal cord injuries always have to be log rolled. They have to be moved in a certain way. We always want to maintain that spine in a vertical manner, straight manner. We never want to twist and turn them where the spine is going to is going to be twisting. So you definitely don't want to do that. But again, this kind of scenarios you'll see more in acute care settings, such as in the hospital or a specialized hospital that deals with trauma. All right, let's take a break, Erica. And let me see here. Can you make time later on? I'll have copies of the workbook. If you want to come by later on, they'll be here for you. And for the other students, I'll message them to make sure they come by and pick those copies up, maybe today or maybe even tomorrow, so you can work on them on those days off. All right, let's take a little break. I'll be right back with you. Okay.
Okay, sir. Thank you.